Brooklyn Independent Television.
As a nation, we are, to put it bluntly, getting older. The youngest members of our largest generation, the baby boomers, are just turning 50, while the oldest are now senior citizens. That means more Americans will be moving into old age at one time than ever before. And yet geriatric medicine is not getting the support and attention it needs to keep up with demand. Here to talk about both the attitude toward elder care as a whole, and more specifically, changing the way it could be practiced, is someone who treats the elderly on a daily basis. Dr. Louis Mudanayak is the medical director of the Cobble Hill Health Center. Thank you for being with us. It's good to see you.
It's a pleasure to be here.
So how big a problem is not having the staff, the geriatricians that are trained adequately with this burgeoning baby boom?
It's a huge national problem, and it's a problem that needs to be taken very, very seriously in the light of the new Affordable Health Care Act.
How is that going to impact it?
Well, we're looking for ways to improve quality of life and reduce cost at the same time. And I think
it's a tall order.
It is an order which would appear to be very tall, but I think there are a lot of areas where we're doing unnecessary things and unnecessary procedures on people who really don't want them. A simple way of looking at this, if you have a child who's having a fever of 104, you'd certainly want a pediatrician to look at the child.
Correct.
But what about elderly Mrs. Smith, who's 98 years old? Wouldn't you want a geriatrician looking at her?
Appropriate care by someone appropriately trained is what we need. And we're not doing it.
We're not experts at the management of chronic diseases. And this is what all of it is about. And part of the reason is the way the reimbursement structures are structured. And the other real issue is people just don't want to do it.
Well, there's not a lot of people who get a lot of enjoyment out of taking care of somebody who's going downhill and the eventual outcome is death. But it can be very rewarding because I practiced geriatric medicine before coming here. So what can we do to remedy this problem briefly?
A lot of it has to do with the cultural context that people find themselves in. Aging is a perfectly natural process. In some areas in the world, you have very little population who are actually sent to nursing homes. You have what we call successful aging, where you can have a 106-year-old climbing an apple tree and plucking apples. Now, I'm not advocating for 106-year-olds to start climbing apple trees.
Well, we don't have that many apple trees in Brooklyn, so.
I think institutionalization is something which should only occur when there's no social support systems in the community to look after these people.
And that's what we need to work on.
And it's a very, very big issue, to have families understand that elderly play a really pivotal role in terms of the experience, their life experiences, and how they can play an active role in family, in day-to-day running of families.
But you know what I want you to tell me? I want you to give me a concrete example of something that's happened to one of your patients, which you take care of the elderly all the time, as a result of this lack of appropriate care.
Absolutely. I'll shorten her name to Mrs. GP, and GP doesn't mean general practitioner, by the way.
Okay.
This is lovely, lovely elderly lady who's two nephews. She was looked after by two nephews. Had taken her to see a physician, and she was on 15 medications.
First problem, 15 medications.
Well, you have this concept of what's called polypharmacy, and it's really a very simple concept. Poly means too many, pharmacies, medications. And so you have to go back to the basics and look at the risks and benefits of each and every medication and the drug-drug interactions. That's the interactions of those medications.
But I want you to explain something to the audience, because many people that will be listening to us will not consider the aspirin that they're taking, the Tylenol that they're taking, the omega-3 oils that they're taking, the Dulcolax tablets for their bowels. If the doctor doesn't write a prescription for it, they don't think it's a medication. Would you address that?
I think the use of over-the-counter substances and medications is families who are taking care of these people, and these elderly people themselves have to realize that they do have adverse effects. They do have drug-drug interactions. But what I'm initially far more concerned about are prescribed medications, which these people are on. I remember the classic example when I was doing my fellowship in North Shore, and my mentor took me to see this little old lady who lived in the community. And he said, when I found her, she was eating cat food. But she had her calcium channel blocker. She had her, a whole bunch of expensive medications. So what were we doing? Prescribing medications where the woman couldn't afford these medications. You have drug-drug interactions where you get one medication that's prescribed by, say, one specialist, say a urologist, just for an example. Another specialist comes along, he's a neurologist, and he prescribes this. A third specialist, who's a cardiologist, prescribes that.
So back to Mrs. GP.
And so Mrs. GP was one of these who was on 15 of these medications. And so what I did is I looked at each of the medications in terms of risk-benefit profile and in terms of interaction with the other medications.
Was she symptomatic in any way from the polypharmacy?
I believe that she was what I considered to be schlogged. Schlogged was out of it.
Out of it.
And she had a family that really adored her in every sense of the word. And we got her off a lot of these so-called unnecessary medications, which were probably causing sedation and other adverse effects. And lo and behold, she started eating her tuna fish with a fork. Now, that really had big impact on the family because it was something that hadn't been there for the previous 6 months.
So you, by going through the medication, taking off the ones that she didn't really need, you improved her quality of life, including her activities of daily living.
Absolutely, and that's where functionality comes in. When you're a geriatrician, you focus all the time on the function of the person. What are we doing, giving this woman an expensive lipid-lowering drug? She's 92.
Yes.
There's no data to show that it actually prevents either primary or secondary coronary arterial disease. And she's anorexic. She's not eating. There's a reason why she's not eating. She's on drugs that suppress her appetite. That being
Absolutely.
one of them. And it's also quite expensive. She has a copay on that.
When someone suspects that a medication is the cause of their problems, would you, in the time we have left, tell the families and the patients who are listening what they should do? What steps should they take if they think a medication's not agreeing with them?
The first thing is they should write down what is different. So mother is more sedated. Mother was throwing up. Mother's constipated. Constipation is one of the biggest problems for the elderly that's simply not addressed, and it really reduces their quality of life. Mother, mother looks flushed. Whatever it is they're seeing, write it down, not in medical words, but in their own words. Call the healthcare provider, whoever it is, and say, look, you started mom off this medication, and they could probably read off what the medication is, and we are experiencing this right now. They should certainly respond, or a nurse practitioner or somebody in the office, well, you should talk to Dr. So-and-so about this.
Unless it's an acute problem, and then they take them with all the bags of medication. And go
Absolutely. I mean, one of the most important things being a geriatrician is asking people to come in with this bag of medications, because they've been taking these for years and years and years. They're beautifully arranged in the most magnificent, sometimes ivory, sometimes plastic pill boxes, and they don't need to be taking them.
And they don't need to be taking them. We're going to have to leave it there. Dr. Mudanayak, thanks for being with us.
Watch this and other Brooklyn Independent Television episodes online at brickartsmedia.org/BIT.